Welcome to the second video in the Domestic Violence and Abortion Care series. This module, entitled Reproductive Coercion and Forced Pregnancy, the Role of Medical Abortion Providers in Enhancing Women's Reproductive Autonomy, explores reproductive coercion as a perpetrator practice. It provides concrete steps for practitioners in supporting women to gain reproductive autonomy through safe and appropriate contraceptive options. As covered in Module 1 of this series, women experiencing violence and control are overrepresented in those seeking abortion care. One significant explanation for this is the issue of reproductive coercion as a perpetrator practice. There is a growing body of literature on male partner influences on contraception and pregnancy decision-making. These influences, when used as a form of control, are referred to as reproductive coercion. Reproductive coercion is any perpetrator behaviour aimed at establishing and maintaining power and control over a woman who they are, were or seek to be in a relationship with by interfering with her reproductive autonomy. Strategies may include denying her control, decision-making and access to options regarding reproductive health choices. A forced pregnancy can be used by a perpetrator to elevate the status of a relationship or be leveraged for resuming a relationship that was ended. As implied in the definition, status does not define risk. Perpetrator behaviours aimed at coerced pregnancy can be classified as pregnancy pressure, contraceptive sabotage and pregnancy outcome control. Pregnancy pressure often takes the form of emotional and psychological manipulation to encourage a pregnancy or deny a woman the opportunity to become pregnant. It may be backed up by threats of consequences. For example, a perpetrator may accuse his partner of infidelity and demand pregnancy and motherhood as proof of commitment and monogamy. He may threaten to end the relationship if this is not complied with. There may also be threats of violence as a consequence of contraceptive use. Contraceptive sabotage can range from tampering with condoms and destroying oral contraceptives, to denying access to emergency contraception, and more concerningly, forced sex and the forced removal of contraceptive devices. Pregnancy outcome control also involves a wide range of tactics, including denying access to finances for an abortion, preventing access to medical care, threats if the pregnancy is ended, emotional manipulation, such as threatening suicide if she goes through with an abortion. Reproductive coercion is an emerging area of knowledge in Australia, and as such, we have no comprehensive national data on prevalence. Data collected by Children by Choice in relation to Queensland women shows about 12% of all contacts report reproductive coercion. Population studies in the United States of America report rates of about 9% of all women disclosing reproductive coercion. Both Children by Choice data and international research confirms that some women disclose experiencing reproductive coercion as their first experience of control or in the absence of naming other forms of violence and control. As such, generic domestic violence screening questions will not pick this up. For this reason, it is important to directly ask all women presenting for abortion care about coerced pregnancy. The screening tools available for download from this site offer the following question. Has anyone forced you to become pregnant when you did not want to be or did not feel right about it? If clinic time pressures make thorough screening for coerced pregnancy challenging, then focus on those most at risk. Our Queensland data also shows that women most likely to disclose reproductive coercion are from culturally and linguistically diverse backgrounds, or identify as Aboriginal or Torres Strait Islander, or are in their 20s. Extra care may also need to be taken in assessing this issue with teenage women, as they may be at elevated risk of coerced pregnancy, but less likely to disclose and more likely to continue the pregnancy in the context of a violent relationship. A downloadable resource entitled Who Controls Pregnancy Decisions in Your Relationship may be useful where you are concerned for her but sensitive inquiry does not result in a disclosure. Medical abortion providers can play a very important role in supporting women's reproductive autonomy by assisting women to access contraception less vulnerable to detection and sabotage as part of abortion care. This helps to prevent future unwanted and coerced pregnancies. A downloadable PDF to support you in this work is available from this site, and printed versions of this resource are available from Children by Choice. This resource will support you to explore the unique circumstances and knowledge of her own situation and allow her to assess the degree of comfort with the options presented. Important factors to consider include whether the perpetrator is likely to monitor the woman's Medicare or pharmaceutical benefit scheme records, restrict or monitor access to healthcare professionals, monitor menstruation and fertility patterns, engage in severe physical assaults, or be actively searching for the use of contraceptive drugs or devices, engage in rape and other forms of sexual assault. If the woman is cohabiting with the perpetrator, this may further inform suitable contraceptive choice. The impact of violence and control on the woman's daily routine, the realities of surviving the day-to-day, as well as the impact on trauma in memory are very real considerations for contraceptive choice in the context of violence and control. If you are needing to resolve the issue of contraception for the woman in a single contact, if she's unlikely to return for follow-up, this will also restrict contraceptive options. Whilst a return appointment after medical abortion is crucial to good care, regrettably, many providers report losing some women to follow-up. For this reason, many medical abortion providers opt for Implanon insertion at the time of administering the mifepristone. As patterns of violence shift and change, arrangements around contraception may need to be reviewed. Encourage the woman to recontact if she becomes concerned about the safety of the contraceptive option she chooses. If you are concerned about a woman not having a plan for contraception after leaving the clinic, consider offering information about emergency contraception options. Whilst available over the counter, a script for the oral emergency contraceptive can help a woman access advanced supply from a chemist more easily. For women experiencing violence who end a pregnancy against the wishes of the man involved, the post-abortion period may have particular safety implications. The ending of the pregnancy may be the catalyst for previous patterns of control to be returned to and to be escalated. If you are concerned about this issue, it may be important to consider referring the woman to a specialist domestic violence service for further risk assessment and safety planning. You may find it helpful to download the DAISY app to your consulting room computer. This app and the 1-800-RESPECT website can be used to locate the specialist domestic and sexual violence service nearest to your patient. Some men may use both coerced pregnancy and coerced abortion in their practices of intimate partner violence and control, so it is insufficient to just ask about one. The next video in this series looks more closely at the issue of coerced abortion.